And final webinar in the series focused on community-defined practices for ethnic and cultural populations, brought to you by the California Institute for Mental Health and the Center for Multicultural Development, and presented by our partners, the Asian Pacific Policy and Planning Council. We would like to thank our sponsors, the Mental Health Services Act and the Department of Health Care Services, for supporting this webinar series. Our webinar today, entitled Lessons Learned from Caring for Our Families in the Asian Pacific Islander Population, will address how implementation of evidence-based practices with Asian Pacific Islander communities requires cultural competence and clinical experience. Presenters will highlight lessons learned from the development of community-defined practices designed for caring for our families of the API population in Los Angeles, with recommendations for practitioners, researchers, and trainers. It's a privilege to have with us today our presenters today, Dr. Sheila Wu, Dr. Lan Nguyen-Chawkins, Dr. Karen Cheng-Lim, and Ms. Michi Okano. Dr. Sheila Wu is the Assistant Director of Asian Pacific Counseling and Treatment Centers in Los Angeles and a licensed psychologist in California. She has been with APCTC since 1992 after completing her National Institute of Mental Health postdoctoral fellowship at the Neuropsychiatric Institute at UCLA. Her areas of expertise include culturally and linguistically competent mental health treatment modalities for members of Asian and Pacific Islander communities, including children, youth, adults, and older adults. Dr. Wu was a principal investigator of the Family Connections Replication Study. She's a trainer for Caring for Our Family program, a community-defined evidence model in LA County. She serves as the chairperson of the CFOF Clinical Oversight Committee. Next is our presenter, Dr. Lan Nguyen-Chawkins, who received her MA from Santa Clara University in 1991 and her Ph.D. from the University of Southern California in 1996. Her dissertation focused on Vietnamese Americans embedded in multicultural context, structural equation modeling of acculturation and family. Since 1991, it's been her privilege to provide therapy to individuals and families from diverse cultures. Presently, Dr. Nguyen-Chawkins is a program manager for Asian Pacific Counseling Treatment Centers, Metro, which provides therapeutic services in the languages of our clients: Cambodian, Vietnamese, English, Spanish, Cantonese, Mandarin, Quechua, Thai, Laotian, Korean, and Tagalog. Our next presenter is Dr. Karen Cheng-Lim. She's a licensed clinical psychologist with more than 13 years of experience working with children, families, and adults. She's been with Asian Pacific Counseling and Treatment Centers since 2000 and is currently the Program Director of Child and Family Services at the Maine Center. She oversees various programs, including APCTC's Child and Tay Full-Service Partnership, Prevention and Early Intervention, and school-based mental health programs. And finally, our last presenter is Ms. Michi Okano. She's a licensed clinical social worker and clinical director at Pacific Asian Counseling Services, or PACS. PACS is a private nonprofit organization which has a contract with the LA County Department of Mental Health and the LA County Department of Child and Family Services. As clinical director, she provides clinical oversight to the mental health programs for the agency's 3 sites. PACS is a specialty service provider serving the Asian and Pacific Islander children and families. The multilingual and multicultural staff provide comprehensive services, which include school-based services, full-service partnership for API adults and children, CalWork supportive mental health services, and parenting education and support groups, targeted case management, and medication support services. At this time, it is my pleasure to turn it over to Dr. Sheila Wu.
Yes, hi, good morning. Today we will be sharing the community-defined practice of caring for our family model in Los Angeles County. And as you mentioned, we have 4 presenters, and each of us will share different components of the lessons learned from CFOF practices. Having trouble moving the slides forward right now.
Okay, give us a second and we'll get them moving for you.
Thank you.
Okay, you should now have control, Dr. Wu, with the slides.
Okay, it's still not moving.
Hey, Dr. Wu, this is Camille. There's a delay when you're clicking the slides. So if you click onto the PowerPoint screen, you should be able to move the slide.
Okay, here we go. Thank you. All right, so we will have 4 presenters today, and the agenda, we've already done the introductions. I'm going to talk a little bit about the background on the caring for our family model. I think in order to understand the lessons learned, you have to know what the model is. We are going to do a case study for you, and we will also talk a little bit more about evidence-based practices with API children and families from PACS, and we'll have a Q&A session after. The objectives today, hopefully you will identify some of the limitations. We are going to share with you some of the barriers and the struggles that we have in implementing the CFOF. Also identify some strategies for advocacy and modification of the CDE practices within the API community. And let me see. Okay, so I'm going to be presenting first on the model. There was some feedback from the previous 2 webinars that they wanted to see the faces of the people talking. So we made an effort to put in our pictures so that you'll know what we look like and kind of hook up with the picture and the voice. Okay. Family Connections and CFOF actually is very closely tied. Family Connections program was developed by Dr. Diane DePamphilis over at the University of Maryland, and she had worked with the child welfare programs. Initially, when we had contacted her about this program, we were using the Family Connections, but the wording and translation for API communities didn't fit too well with the Family Connections. So we had worked with the developer and changed the name to Caring for Our Family, which in translating into API language made a lot more sense for us. And I will talk a little bit more about that. CFOF is a community-based family strengthening outreach service program designed to support vulnerable families to meet the basic needs of their children without the need for formal public child welfare service. So all the cases that we take in, they don't have open cases with the Child Protective Services, CPS, or DCFS. Family Connections was specifically designed to reduce the risk factors associated with neglect and enhance the protective factors that may help families more adequately meet the basic needs of their children. In 2002, I'm trying to forward the slide. It's stuck. Oh, there we go. There's a delay. In 2002, there was a grant proposal from the Department of Health and Human Services through the Office on Child Abuse Neglect, Children's Bureau, and the Federal Replication Studies. And so our agency, Asian Pacific Counseling and Treatment Centers, had submitted a proposal based on Family Connections model. And we were awarded a 5-year grant, along with 7 other agencies across the nation. So after the grant ended in 2009, Family Connections continued to receive grants and recognition and continue on with further studies in other states throughout the United States. And as you can see in this grid, you can see the history of Family Connections and how it got started. Our involvement is in the middle, where you see from 2003 to 2009, we were selected as a demonstrated effective program by the U.S. Department of Health and Human Services. And there were 8 replication sites. There were 2 in California, and both of them actually are in Los Angeles. And Dr. Diane DePamphilis continue on with further studies. Currently, this program is in Colorado, New Mexico, New Jersey, in Nevada, Texas, in Maryland, and of course in Los Angeles. Recently, I've received calls from New York, from their Department of Mental Health. They're also looking into possibly implementing Family Connections, Caring for a Family in New York State. So it's actually very exciting work that Dr. DePamphilis is doing right now. James Bell Associates have been involved with us since 2002, and they are a consulting agency who gathers all the data and does the cross-site replication evaluation reports for us. And I will talk a little bit more later on some of the studies. For Family Connections, we use a logic model, and for those of you who are familiar, this must look, this must hit you at home. But as you can see from the diagram, it actually helps us to become more focused on the flow of the services. So we eventually will reach the goal of our long-term outcome, which would be to increase child safety and improve child behavior. We have a intervention model manual that we use for this program. It is close to about 100 pages long, and it includes all the theory practices, the process of what a clinician and a case manager need to do to provide an intervention, and it helps us to guide the service delivery. These are the core intervention services. It includes outreach, intake and screening, crisis intervention, emergency and concrete services. In Baltimore, what they have is they actually have flex funds to cover for purchasing utility or refrigerators, etc., for the families. Unfortunately, in LA, we did not have that kind of luxury in funding, so we provide a different type of emergency concrete services here, and we will explain more later. Family Connections also includes comprehensive family assessment, and then we use an outcome-based service planning. All the services are individually tailored, so depending on what the family comes with their problems, we would tailor it individually. And we provide individual and family counseling, advocacy and service facilitation, and case management services. And what's also important is to have outcome measures that could help us evaluate change over time. And when we close the case, that we're able to see the improvements in the families. These are some of the fidelity criteria that I've included for you. And this is what's expected from all of the agencies that are involved in providing Family Connections model, that they have to follow the philosophical principles, the program structures, the administrative activities, professional development activities, and research activities. And in the next slides, I have spelled out the specifics on what's included in the philosophical principles. These are looking at really the ecological development, looking at the community, what kind of outreach is needed in each of the communities, using the family assessment tools to provide individually tailored interventions, and providing the helping alliance with each of the families, and also empowering the caregivers. And we use the strengths-based model. And we also have our staff trained in cultural competency. And again, all the service plans are outcome-driven. And we also provide focus to the practitioners to see what they need. In terms of the program structure, we have to see the client, the family, within 1 business day of the response. And so within 24-hour turnaround. And the reason we do this is when they call, we want to get them while they are interested and motivated. Once we wait, sometimes we get busy and families just sometimes try to minimize the problems. And so we want the turnaround time to be really quick, so we have a 24-hour turnaround time. We must provide at least 1 hour weekly service. These have to include individual, at least 1 hour, plus family visits if necessary. And we provide a comprehensive family assessment with clinical assessment instruments. And we will talk a little bit more in the outcome measure section in our discussion later. And outcome-driven service plans, again, hoping that we could, at the end of the day, really increase the protective factors and decrease risk factors, and having to evaluate change over time. There are references that I've put in the back, and I think after the webinar, we could provide that up in the link for you with some of the resources that we've included. In terms of program administration, we have individual manuals, intervention manuals that I've shared with you in the previous slide. That's close to 100 pages long. So all the clinicians and case managers have to read through. And that's kind of like the manual that they have to follow through in order to do the program successfully and keeping to the fidelity of the model. In addition to that, there's also quality assurance procedures, risk management, and then we also track time units. Professional development, we do provide the training for the clinicians and case managers who will be working with the families. We expect that each of the clinicians and case managers will receive weekly supervision from licensed clinicians. And you know, again, in keeping with the fidelity of the model, we would like to provide as much as possible close to what the original model calls for. And research and evaluation, as I've gone through in the chart for you, that we use a logic model. We have outcome measures to measure change over time, and there's also a documentation of the process of innovation, and we implement strategies that document the process of implementation and service delivery. Okay. So here comes where kind of like our part in APCTC. In 2002, as I mentioned earlier, we were awarded a grant to replicate family connections. There were 8 sites in the United States, and I did kind of a summary for you with the 8 replication sites. As you can see, it ranges from California to Michigan to other states, and I've actually done a little map for you here to tell you where the services are. And currently, in addition to these locations that did the replication site, we're also in Nevada, New Mexico, Colorado, Texas, New Jersey, and then maybe New York. So Family Connections, through Dr. DePamphilus' leadership, has really expanded throughout the nation. And a lot of the programs are getting a lot of benefits to it. So I have a lot of information actually to share, but I know that we have limited time. So I'm just going to go through very quickly on what our research findings are. The overall impact of CFOF families at APCTC. For our study, we focused on 2 API groups, the Korean community and the Cambodian communities. And when we wrote the proposal in 2002, we had gathered census data in LA County, and then we obtained demographic data from LA County Department of Children and Family Services. because keep in mind we want to look at families who are at risk. And so through the Department of Children and Family Services, the data has showed that in the Korean community had the highest number of reporting of child abuse and neglect. In the Cambodian community, they had the highest number of substantiated child abuse and neglect. So instead of focusing on 10 or a dozen different API communities, we picked the two highest numbers and serve and concentrated basically in 5 years of study with these two communities. You'll hear later a little bit about some of the difficulties that we have in doing the outreach. But now getting to some of the data, in this, what we had done was random assignment with a 3-month CFOF program and a 6-month CFOF intervention. Now, at the end of the day, most Cambodian families and Korean families, they welcome the services and they also show improvement since from the beginning. We had a really small sample size. I think initially the first couple of years was very difficult for us to outreach and engage the families. There was a lot of stigma still around, and there were a lot of resistance in having professional people coming into their homes and into their families because there was just a lot of stigma still at the time. But we did manage to have more families involved during the last 3 years of our research study, and I will show you some data later. Dr. DePamphilus had, along with James Bell Associates, who does the evaluation for us, had done a symposium in 2010 to share studies on the multi-site findings. And this is what we found for all the 8 sites together. Of course, one of the conditions is to have the random assignment to all the different conditions, focus on the primary caregiver, and with 1 index child from each of the families. There was assessments done at baseline, at post-test, and also 6-month follow-up after the case was closed. Regardless of the condition of the families, they all show significant improvement over time. And we actually used 11 different outcome variables. So you can imagine it was quite difficult to get all the outcome measures back from the families, and it was quite a struggle, especially with our Cambodian Korean families. And we'll talk a little bit more about some of the barriers that we have. But family connection did show different impacts on child behavior problem, caregiver, depressive symptoms, and parental stress. And fidelity to the model was also kept.
Excuse me, I don't mean to interrupt, but I did want to just ask, can you speak up a little bit louder? Some of the participants are having a hard time hearing you, okay?
Okay, sure.
Thank you.
Let me maybe boost up the volume. Is this better?
A little bit. I don't know if you can move your microphone closer to your mouth.
Okay, so I just moved the microphone. Okay, so this is an example of looking at just one of the outcome measures that we had. This is the Achenbach Child Behavior Checklist, and it's just on the externalizing behavior. You can see the comparison in family connection treatment versus the typical service. So at baseline, for example, for family connections at 58, post-test shows at 54. Then a follow-up 6 months later, it continued to decrease, which means that the families are doing better, they're improving. A typical service, in the follow-up, actually some of the behaviors came back up. We had also have a publication in the Protecting Children American Humane Journal, and this includes all of the 8 projects that was done in the replication study. So I put in the link information for you if you are interested to read more about the family collections model. You can also just Google and put in American Humane Family Connections, and it should come up for you. It's in a PDF. And these are the articles that are in the publication. And you can see we are the second article. Our article is on culturally competent practice with Cambodian and Korean families in Los Angeles. Okay, so this takes to where we are today. So in 2009, there was a proposal in the state of California through the Mental Health Services Act and through the PEI, Prevention and Early Intervention. And we had submitted CFOF as a community-defined practice in Los Angeles, and we were awarded the funds. Given that because we could not do what we did in the research where we used 11 different measures, so this time we chose only 2, and that was the requirement for the developer, Dr. DePamphilis. And so we included the family assessment form and the Achenbach, the SIBA. And we want to see what the overall impact of the family is in terms of the mental health issues, the depression, the anxiety, and the stress, the parenting skills, competency, and child well-being for what we're doing now in Los Angeles. We felt that CFOF had demonstrated effectiveness in the cross-site evaluation of the 8 replication studies. So we wanted to see whether this will work in Los Angeles with also the multiple agencies, but at the same time maintain fidelity to the original Family Connections program. We have included 3 of the SSG programs divisions, which is the Asian Pacific Counseling and Treatment Centers, the Occupational Therapy Training Program, OTTP, and Weber Community Center. And then we have invited 2 other agencies that are non-SSG, and one of them is PACS, Pacific Asian Counseling Services, and we have one of the speakers here today who will talk to you about the lessons learned in PACS, and then one other agency, which is the Tessie Cleveland Community Services Corp. So currently we have 5 different agencies. The way that I've set it up is that we have monthly meetings with each of the providers where they would send representatives. And every month, the Clinical Oversight Committee meets. This is so that we can keep to the fidelity of the model. So in our monthly meetings, we discuss administrative issues, provide technical assistance, and we do a clinical case discussion. And what we do is for the 5 agencies, we rotate, so each of the agencies will provide 1 case per month, and then we rotate. We also have Dr. Sylvia Yen, as you can see her picture on the bottom left, who monitors and is our quality assurance director for this committee. And again, this is so that we can keep to the fidelity of the model. We also are very happy that we have a research and evaluation team member, which is Mr. Eric Watt. He works out of our core office and helps us to analyze some of the data that we have. And one of the other requirements from the developer is that we would submit 6-month progress reports. And this would track how many clients are seeing each of the agencies, what are some of the services that are being provided, how many hours in each of the units were served, and what was the outcome. And so this, again, is it's something I think some of the other EVPs, I'm not sure if this is done, but I think this really keeps us on our toes and to make sure that we're keeping to the fidelity of the model. And I also provide reports to the developer periodically. Okay. One of the unique things about CFOF is that we have a community advisory board. And I'm not sure if there are other models in LA County that has this, but we try to obtain diverse representation. And we ask each of the partner agencies, the 5 agencies, to invite people in their community who they think can best represent their community. And so these are the folks that we have. We've invited them to come out to give us input. We consult with them to see, what is needed in specific communities. And one of the person that I want to note is number 6, Dr. Jacqueline McCroskey. She is a professor over at the University of Southern California. She's also the developer for the family assessment form, which is one of the outcome measures that we use. And so it's really great to have someone who's developed one of the outcome measures to be part of our community advisory board who can really give us just really valuable consultation and support for our program. We've done several trainings, and I've included some of the pictures for you. We've trained over 350 staff throughout Los Angeles County in the past, 7 trainings that we've had. And we will continue to do it as the needs arise. And so here again, to just kind of recap what CFOF core intervention services include. Okay. We have a referral criteria checklist. It is 1 page, and this is how clinicians and case managers can determine whether the family is a good fit for caring for our family. I'm not going to go through it because it's pretty detailed. But the following few slides has the operational definitions. And the reason why we make it so specific is because there are 5 agencies serving the communities. And we want to make sure that we are all doing the same things, keeping to the fidelity of the original model. So the next few slides explains and has definitions of the criteria. Okay, so now we're to talk about the outcome measures. In CFOF, currently we have used the family assessment form, and we take the data at intake, at baseline, and at 3 months, and at 6 months, or at discharge. And then we also use the CBA, the Ockenbach, at intake, at 6 months, or at discharge. And we have been doing that since 2009, 2010. But most recently, our funder, LA County Department of Mental Health, have required additional outcome measures, which includes the YOQ and the ECP or the CESP. And so we have added the measures into our program. But again, like I have said earlier, it was quite difficult to get the data collected with our population. So after some struggles, I've discussed with the developer, Dr. DePamphilis, and she agreed that as long as we have 2 outcome measures that we're able to measure change over time, it will be okay, that we can still continue to keep the fidelity of the model and then have the outcome measures that can measure change over time. So in this situation, I think the developer's flexibility, we really, really appreciate that. And at the same time, we can still collect the data that we need. So currently what we use is the FAF, which is the Family Assessment Form, and then the YOQ and the ECB-CESP. And so this is the preliminary data that I have. And I think this actually is a typo. It should be cumulative data through March 2014, not 2012. And since we don't have a separate funding for our research evaluation, I've just asked a favor from our research evaluation staff to help us analyze some preliminary data for us. And this is the data that we have currently. We have 647 clients that we've served. And this is the breakdown of the demographics with gender and the race and ethnicity. Unfortunately, some of the data are missing. And so you'll see down at below, there's a missing data of 67. And most of them actually are the API. And I think part of the reason is because it was really hard to collect some of the data. And we can explain more later in our later sections in the lessons learned. And this is a preliminary data again on through this one actually is through March 2012, before the outcome measure changed, and this is with Ockenbach. Because remember, after the outcome measure changed, we no longer use the Ockenbach child behavior checklist. And as you can see from here in comparison, in internalizing, externalizing, and total problems, on baseline and 3-month follow-up, you can see the improvements in the scores in this. And finally, some FAF data, the Family Assessment Factors data, that indicated improvement over the 6-month treatment period in all of the 5 factors, which include cleanliness, orderliness of the home, financial conditions, support to caregiver, preliminary caregiver, primary caregiver and child interaction, and development stimulation. So that's really just a very brief kind of data set for you to see that at baseline and at discharge, which is at 6 months, that you can see a significant difference in all the 5 factors. So again, I apologize for not being able to show more data to you, and we also have the time constraints. I know I've talked over my time. So now I'm going to turn over the screen to my colleague, Dr. Nguyen-Chawkins, and she will be sharing with you a case study and discuss some of her work with a particular family using Caring for Our Family intervention. And here's Dr. Nguyen-Chawkins.
Good morning. I'm happy to be here to share about our case study. As a therapist who had worked a long time, I didn't expect to learn as much as I did through the process of delivering services in this modality through CFOF. My case study is of an East Asian family with 3 young children. The youngest is a toddler. Okay. And the next child is a 3-year-old, and we also had an early primary school age child at 6 years old who was in 1st grade. The mother was a CalWorks client, and her therapist had referred her due to she admitted to feeling out of control and losing her temper frequently. The family was undergoing a multitude of stressors. It was at the time of the downturn of the economy. She had a financial crisis. They foreclosed on her family home. She lost her job. She was facing legal problems and experiencing fights daily with extended family on both sides. The parents at this point were not speaking, except for the occasional fight. And absent father was absent daily. He was really absent. Mother was discussing how she was just feeling very overwhelmed, depressed, experiencing intense distress, and at one point in the treatment admitted to using alcohol to cope. So we wanted to immediately assess for whether the family was a good match with CFOF. CFOF is a PI model that is strength-based, so I want to start off with some of the clear strengths that this family had. Mother appeared very intelligent, extremely motivated, and she expressed insight, the capacity to care. She really was distressed by her yelling and her inability to control it, and was very concerned about the impact of her children, on her children. The children appeared very strong, very healthy, very, having very good nutrition, and they clearly wanted to engage with each other. So one of the first issues that Mom brought up in our very first home visit was that the children were unable to sleep through the night. And it was a very severe situation where all of the kids were getting up every probably 90 minutes. And so Mom would have to put them down throughout the night. And as well, they were also experiencing, the 2 older children were experiencing school difficulties. They both had difficulties adjusting to preschool, and Ashley had left preschool prematurely. The 6-year-old child at this point was not talking at school at all, and only minimally at home. She was also wetting her pants daily at school for at least 2 weeks straight. So what we found in the Ockenbach scores for the 6-year-old child was that she was in the clinical range in both the internalizing and externalizing behaviors. She was emotionally reactive, cried easily throughout the session, cried unprovoked, appeared very anxious and depressed, was withdrawn, and it was interesting that she also scored in the clinical range on aggressive behavior because that was not seen in the session at all, but Mom clearly endorsed that in the measure. In the speech area, Mother noted that she was very worried about the child's lack of development and spontaneous speech. She would whisper one-word responses to questions. The teacher also reported concern about the child's withdrawal and depressive affect. The 3-year-old is very interesting because in our very first meeting, after about an hour and a half, she came out with a toothbrush and started brushing her arm and her teeth. And her mom was saying, is this play or is this distress? What is going on? I can't get her to stop. So the child was brushing her teeth or her arm 5 times a day, half an hour each time. And the Achenbach scores suggested a very distressed child. Mother had endorsed all clinical range in almost all areas. She was emotional reactive, she was anxious, depressed, withdrawn, sleep problems. She had attention issues. She was very aggressive and a very stressed child. She, in session, she would at times just, without being provoked, throw a hard toy across the room. So she was a very angry child. So first of all, what we wanted to do was make sure that Mother was attending to individual therapy to address her depression, issues with her husband and her family of origin, and then also as we were working midway through our 3 months, Mother admitted to her relationship with alcohol. She was drinking to experience her feelings, she was saying. So when the children were put down to sleep, she would drink and black out, actually. So it was pretty severe. We also provided family therapy for Mother to engage with the children, to bond with them, and family therapy for the siblings to decrease the family tension. What was interesting in this family therapy was that Mom, Ashley, had not had, she had actually had the children taken care of by the parents, by her mom, and would see them on the weekend. So when she lost her job, she was able to stay home with the children, but the bonding was not there and the children were not used to her. So there was a lot of work to be done. And the children were very jealous when they saw Mother holding the baby, because that was not something that they had experienced. And grandmother was very emotionally expressive and easily angered. So the children, there was a lot of work in terms of bonding and attachment with both of the older children. So our home visit was to identify the environment and what was setting up the family that prevented good sleep hygiene. It was interesting because there were light fixtures in all areas of the home, and it was almost like a nighttime playland because some of the light fixtures were, of shapes of stars and toys. And so our first work with Mom was to provide some psychoeducation around sleep hygiene, and also to stabilize this sleep so that everybody could have a foundation to work on in therapy to decrease the irritability that was presented in all family members. I also wanted to assess living conditions that contributed to poor coping skills, including daytime and recess. This family environment was very, very clean, actually, and it was a strength. There was so much enrichment, a lot of toys, books, and very, very actually excellent in many ways. One notable factor in the living conditions was a lot of refrigeration for fruit juices. So we identified one of the conditions that actually made it harder for the child to in terms of her enuresis, was having too much sugar and juice. Okay. So in terms of the outcome, we saw that the 6-year-old exhibited improved coping skills and relational skills that were more reflective of her age. She began to speak at school, she made friends, and the enuresis stopped. As you can see from the CBCL scores after 5 months of treatment, that almost everything went into the normal range except for the emotional reactive factor, which was borderline clinical. So she actually made tremendous improvement. For the 3-year-old, she no longer exhibited the OCD behaviors and hitting. She entered preschool, made friends, and most of her scores went down to the normal range or borderline clinical range. There were some that were still in the clinical range, but the scores were significantly lower if you can compare to the initial assessment scores. The parent-child relationship greatly improved. My children and mother were both more expressive in their communications to each other. The children were less demanding and anxious. We worked a lot on mom having time with each of the child separately because they had not been together during the formative years. The children needed to kind of have that one-on-one time with mom during the daytime and not at night. That was what they were speaking on, and that was some of the issues around the sleep difficulties. So mom was especially proud of the 6-year-old child saying to her that, Mom, you used to yell a lot, and that bothered me. She was stunned that the child was able to verbalize that to her. The sibling relationship improved. They could play together without hitting. We had a social activity at the clinic, and the children made some art activities together with a lot of other children and oriented themselves physically to each other. They could, be close without hurting each other, and kind of sharing the materials. The father spent more time at home. The couple argued less. Mother accepted their relationship, what father could bring to the relationship, and I mean, it wasn't great, but there was no more arguments like the past. The FAF scores, mother reported a decreased distress. She said that initially she felt a 9 out of 10 or 10 out of 10 stress, and at the time of discharge she said 3 out of 10, manageable. She reported using coping skills to manage her difficulties and not using alcohol. Although she had stopped using alcohol, we had talked about she was her strength was she was very motivated to take care of her health for her children, as well as continue learning. And we had talked about the impact of alcohol on the brain and on the organ, and she really kind of worked really hard to shift gears. However, she did kind of utilize the computer as sort of the friend in place of alcohol. So she reported that from caregivers, the distress 4 out of 5 went from 4 out of 5 to 1.5. The children were enrolled in enrichment programs that were very helpful because there were parents involved in these programs. The teachers became a support for mom as well, so she really received support from other parents and from teachers and learned some of the developmental needs of children through the teacher as well. As noted, the caregiver-child interactions went from 4.5, which is critical, to a 2.0, as well as mom was also more able to take authority role and communicate more effectively to her children. She noted much increased capacity to control her impulses, to control her aggressiveness and anger, and not take it out on the children. In terms of going back to this, Ashley also, mother was able to work through some of her difficulties with her own mom and make a referral for her sibling, her own sister. So she made referrals for both mother and sister was found to have Ashley's psychosis. And and sister, who was an aunt to the children, were really in the children's life. So it was actually really important that mom get those referrals as well, so that she could not feel weighed down by being a caregiver to not only her children but also her sibling and her parent. Okay, so I just wanted in summary to say that the CFOF strategies and concrete team services really did help us clarify the outcomes and move towards the outcomes in a quick and effective way. We did notice that a few of the subscores rose to a critical level during the mid-wave assessment because, as noted, the parent revealed family trauma and alcohol abuse after this initial assessment. I wanted to just point to that what I really liked about the FAF and the CFOF was that we were able to examine a lot of the factors very thoroughly and carefully, and it really did help us in our treatment by, for example, understanding that the children had been taken care of by grandmother for most of the days in the week, and understanding that which had impact on the parent's child understanding of child development. So that really helped us understand that we need to work with the parents more thoroughly on understanding what each child needed developmentally. The other cluster, as I already mentioned, was being able to be in the home and seeing, the conditions that affected both the enuresis and the sleep issues really did help. So I just wanted to point those two things out.
Okay, thank you to Dr. Nguyen-Chawkins, who presented the case. And as you can see in CFOF, that we're able to serve the family with multiple children, but using one of the family assessment forms to gather all the data and see improvement over time. And so now I'd like to invite Dr. Karen Cheng-Lim. She will be talking about lessons learned both in the replication study as well as what we're doing right now in our services.
Thank you, and good morning. So as Dr. Wu mentioned, I am sharing lessons learned in both the CFOF replication and the MHSA PEI program. And the API clients we've served were predominantly Korean, Cambodian, some Filipino, and Vietnamese. So with CFOF, what has really worked very well with our API population is the social work approach and cultural adaptability of the interventions. Compared to other EBPs that our agency has been exposed to and trained on, which were more Americanized, and the curriculum and approach were difficult to translate not just into the API languages, but also to the API family's culture. With CFOF, we found that the principles and the approaches were flexible and adaptable even to the subpopulations in the API community. The CFOF practice principles of community outreach, family assessment, individualized services and interventions can be tailored based on the family's needs and cultural nuances. When with CFOF, there is an intervention manual that is focused on principles and process of CFOF, but there is no set therapy curriculum that the clinician needs to strictly adhere to, and that's what makes this CDP adaptable and flexible to the API community. Also, the structure of the family assessment form really helped our clinicians prioritize the specific risk factors in our families, and this has helped guide the clinicians in terms of what to focus on with each of the families. The family assessment is also not dependent on the client and family self-rating, and as we found in our work with our clients in other EBPs, sometimes the rating scales are very difficult to understand with families who may be less educated or unacculturated. Just the concept of rating the intensity and frequency of their problems and symptoms can be a difficult concept to understand. So the FAF, however, is based on therapist observation and interviews. Also, Dr. Bland mentioned that the FAF is very comprehensive. It not only identifies the risk factors, the top 5 risk factors for a family, but it also helps identify the family's strengths, which can be used not only to engage the family in the treatment, but also helps the team build on and enhance the family's protective factors. We've also found that CFOF is most effectively implemented by a team of at least 1 therapist and 1 case manager to address the API family scope of needs. So many of our clients are not only low income, but also recent immigrants, low acculturation levels, and linguistically isolated. So it really helped to have a team to address their scope of needs. We've also found that sometimes it's difficult to find clinicians or therapists who speak certain API languages such as Khmer. So sometimes we'll need a case manager who speaks that language to be able to engage those communities. The support and collaboration amongst the team members is also very helpful to the difficult work. Some of the lessons learned in terms of the barriers we've encountered to client recruitment and retention. So during the replication study, the outreach and recruitment of API clients took a lot longer than expected. And some of the community outreach strategies that we thought would work didn't generate as much referrals. So I'll share later on what strategies actually generated more referrals. In the PI implementation, it was still difficult to recruit APIs. As you can see, the great majority of our CFOF PI clients are non-Asian. Sometimes the referrals were already DCFS involved, or a child abuse report had to be made during the intake, which disqualifies the family from CFOF. Those families will have to be seen in other programs or other evidence-based practices. Another barrier is some parents were reluctant or have difficulty following through with the family sessions, even though before the intake they were informed of the family-focused nature of CFOF. And there are many reasons why parents have difficulty following through. Some of them work long hours or more than 1 job. Some parents don't see the importance of family sessions, perhaps because they have a lack of awareness of their children's mental health issues. Or, example, in our Cambodian clients, perhaps given the history of war trauma and a refugee history, they have a learned sense of helplessness, that they don't feel family sessions would be beneficial to them. Or some may have role reversal issues with their children, so that they don't feel that they have much parental authority. What some of our clinicians have given feedback in terms of outreach to Cambodian families is it seems to be more difficult because of the fear of stigma in such a tight-knit, concentrated community. sometimes the families would fear what the neighbors will think when they are being visited by mental health professionals. Also, the history of trauma from Cambodia has caused a lot of mistrust toward outsiders whom they associate with the government. And compared to the replication study, the MHSA PEI funding does not have a flex fund as part of the funding, as Dr. Wu had mentioned. Flex funds actually could help with client recruitment and retention. What we found in our replication study when we had flex funds available was that even the small grocery gift card incentives for participating in data collection were very helpful in actually retaining some of our clients. Although DMH-PI does not include flex funds, agencies can still try to generate their own flex funds through donations or fundraising. That's what our agency has done. And with those funds, we've been able to distribute school supplies and also donations of clothing and household items. One challenge of implementing a prevention early intervention program is that for API parents, they often wait until there is a crisis in order to seek help. If problems are minimal, they don't see the need for services because they may have other priorities that seem more urgent. So behavior problems in the kids often worsen in adolescence, and that's where we sometimes see the API families reaching out for help when things have gotten worse or when there's already a crisis. I'd like to share some solutions and strategies we found helpful in terms of client recruitment and retention. So one way is to increase collaboration with school and DCFS liaisons to identify referrals. Our agency has a school-based mental health program, and our school-based clinicians have been able to promote PEI CFOF at the schools and generate more referrals. We've also reached out to the Department of Children and Family Services API unit, and they have referred clients with unfounded or unsubstantiated abuse allegations who need prevention and early intervention services. During our replication study, what we found helpful in terms of recruiting Korean clients is offering free Korean parenting seminars and also doing Korean newspaper interviews focused on parenting and how to help children maximize their educational achievement. And this seems to be something that they really get attracted to. Some other outreach efforts that weren't as helpful were maybe at that time during the replication study, they weren't quite ready, but our staff did contact several Korean churches, spoke to the pastors, and promoted CFOF. Also, we attended health fairs, but those outreaches did not prove very helpful in terms of generating too many referrals. Another outreach strategy is to screen children of consumers in our adult mental health program who may benefit from CFOF. Those parents with a serious and persistent mental illness often struggle with parenting and other psychosocial stressors, so those could be risk factors for child neglect and abuse. Another way to get buy-in is to promote the case management component of CFOF to help families address their basic needs. Since many API families have stigma about receiving mental health services, offering the case management support does help to decrease their resistance. Families are much more welcoming to this type of support, especially because many of the families we work with were recent immigrants or they're unaware of community resources, which causes a lot of family stress. So during our program, our therapists and case managers will help link the families to benefits, health care, after school, tutoring, summer camps, and other community resources. The case managers also help with advocacy and support with school-related issues. Parents with limited English proficiency are often unaware of how their kids are doing at school, and they don't understand the paperwork being sent from school. So the case managers really help greatly with that, and that helped to improve the the kids' academic functioning. Just as a side note, some of our staff have given feedback that sometimes the language barriers between the parents and kids were so bad that they've resorted to using hand gestures to communicate with each other, and this really causes a lot of disengagement between parents and children. So having bilingual, bicultural staff were essential in helping these families. Because some of the families are so tight-knit, such as the Cambodian families, once they have built the trust with our staff, then they end up referring other people they know to CFOF. So that was a great word-of-mouth recruitment. Other strategies we found helpful in client retention is to conduct home visits after school to accommodate the parents' availability, especially if they're working long hours or 2 jobs. This does require the program to be flexible in allowing clinicians to work after hours. So sometimes we've allowed staff to start and end their workday later so that they can accommodate these after-school visits. And for parents who are reluctant about home visits, one staff shared this, I thought, very useful approach, which is she tells the families that there is no need to clean up. The home visit is really about us gathering more information about your usual home environment so we can give you insight about what you can change or improve. So I thought that was a really nice way to reframe the home visit approach. If the home is not the most ideal place to conduct therapy, CFOF also allows flexibility to find alternate places, such as a nearby park, a client school, or a quiet cafe or restaurant. We know that sometimes in our families, they live in very small apartments with multiple family members and extended relatives, so the home may not be sometimes the best place to conduct therapy. Also for screening for appropriateness of CFOF referrals, we try to continually improve that. We try to inform parents at the beginning of required family participation and get their buy-in, but that is still an ongoing effort. For parents who may not see the importance of therapy, we try to modify the way we do therapy. Through case management services, we would inject therapeutic interventions such as empowering parents to utilize their resources and to learn to advocate for themselves and their children. We've also used other creative modes such as holding family picnics and outings to improve parent-child relations. In terms of outcome measures, what we found was the family assessment form was relatively easy to complete since it required mostly clinician observation and interviews, and the terms used are not very technical. Also, the clinician's attitude and approach in outcomes collections were important. If the clients and families perceive that the clinician views the outcome collection as important, then they take it more seriously as well. We also try to motivate staff to collect measures by highlighting the clinical utility of the measures and that it's not just added paperwork. Also, a non-judgmental approach is crucial because a lot of API families, especially with the Korean parents that we've worked with, have a tendency to minimize problems and symptoms during the intake. So perhaps because of lack of trust or to save face, they don't reveal a lot of things. So the baseline measure may not always be the most accurate. So that's why, as Dr. Lan pointed out in her case study, there was a spike in scores at the 3-month assessment because the family revealed more problems as more trust is built. So even though the FAF does require more frequent timeframes for administration at baseline and every 3 months thereafter, that frequent data collection is actually helpful to more accurately track and assess changes over time. Other barriers to completing outcome measures are that some of the required outcome measures are not available in certain API languages. At the beginning of the PEI implementation, there was initially no, or the YOQ initially only had English and Spanish translations. Now YOQ has more API translations, but still not yet in Thai and Laotian. The ECBI, the ABERG Child Behavior Inventory, only has translations in Chinese, Japanese, and Korean at this point. Verbal translation is not allowed with the YOQ and the ECBI since this affects the validity of the measures. And even with translated measures, the issue of accuracy sometimes comes up. We have staff who gave feedback that some of the translated words are not the most accurate and come across too formal for the parents, so the clinicians would have to paraphrase. Even if measures do have the API language translation, some parents have literacy issues, especially with our, some of our Cambodian families who are first-generation older immigrants who are not able to read. The clinician has to take considerable time to read the measures to the parents. And due to time constraints on the part of both the clinician and caregiver, this is not always feasible. So these are some of the reasons why we have not been able to collect as much outcomes as we would like with the API population. Also, sometimes it is very hard to get measures back from teachers. Some solutions to these barriers is to continue advocacy efforts with LAC-DMH to translate required outcome measures into all the API threshold languages at least, and to use alternate measures or obtain outcomes from collateral such as teachers if parents are unavailable. For example, the SESB, the Sutter-ABERG Student Behavior Inventory, can be administered by teachers or with teachers if the parent's ECBI rating is unavailable. Using creative ways to get measures back from teachers, some of our staff have attached a letter explaining the purpose and a stamped return envelope. Some staff also have used effective tracking systems or reminders such as the Outlook calendar reminder, Excel spreadsheet with due dates, and supervisors have also used some administrative monitoring tools. It also is helpful to explore if the agency's EHR system has a reminder feature to help with outcomes collection. In terms of fidelity to the model, unlike the replication study with the MHS API implementation, we don't have or we can't afford to have clinicians designated solely to implement CFOF. Our clinicians are serving clients in different programs, have a higher caseload, and are implementing multiple EBPs. So it is harder, it's more challenging to ensure or track fidelity. Some solutions we've found is to, and some of these are feedback from staff as well, is to be able to implement CFOF soon after the training. So at the beginning of the PI implementation in LAC-DMH, agencies had a push to, or felt the push to get as many staff trained in as many EBPs as possible in order to quickly begin to utilize the PEI funding. So it was harder for staff to digest what they've learned. Also, there was a time gap sometimes between the training and the implementation. So this solution, I think, is helpful to be able to, for the program to set it up so that the implementation can be done soon after the training. And this might also require recruiting families before the training ends. I'll jump to number 4. It's also helpful if administratively feasible to train each clinician to develop expertise in 1 to 2 versus multiple EBPs. Unfortunately, this is not feasible for our agency at this time because we have multiple API language coverage needs. So each clinician had to be trained in 2 or more EBPs in order to cover the various client presenting problems with our diverse API population. Regular supervision and feedback in place helps to ensure fidelity. This includes weekly supervision, individual or group, regular chart reviews, and as mentioned earlier, the CFOF Clinical Advisory Committee also helps to ensure fidelity amongst the partners. Lastly, the support and coaching from other CFOF clinicians. Staff can learn from each other how to better address barriers to implementation. So that ends my presentation.
Thank you, Dr. Cheng-Lim, for your information on the lessons learned. I think we will continue to have challenges, and we will continue to try to use different solutions for these challenges. So next, and as our fourth and last presenter, is Ms. Michi Okano, who is the Clinical Director over at Pacific Asian Counseling Services, PACS. She will speak a little bit about her own experience and lessons learned in her agency, as well as a focus group that was done and some of the survey outcomes. So here is Ms. Okano.
Good morning. I'd like to share with you some experiences in implementing evidence-based practice models to the Asian Pacific Islander population, both at our agency and through a report and survey by agencies that participate in the APCON Mental Health Committee. I will start with some challenges in providing best evidence-based practices with API children with API children that we serve at PACS. And PACS has a diverse clientele that includes Cambodian, Samoan, Korean, Japanese, Vietnamese, Filipino, Indian, and also Hispanic. And each ethnic group has specific language and cultural needs. Khmer-speaking case managers who are of the community and are fluent in the Asian languages are part of the treatment team to assist with communicating with the parents of the Cambodian child. For TFCBT, that's trauma-focused cognitive behavioral therapy, we have at PACS, and the challenges to this model is that case managers are not able to receive training in TFCBT, since the minimal requirements for the staff for this training is a master's degree level. And our case managers are paraprofessionals who may have a bachelor's degree or an associate arts degree. So they will not be able to participate with clients to provide this model. Also, case management services is not a core intervention in the trauma-focused CBT model. At PACS, we also have we've had also implemented evidence-based practices of child-parent psychotherapy, MAP, which is the multi-adaptive practices, seeking safety, and other evidence-based practices. In the TFCBT model, we have served 15% of the total clients that have been seen in this evidence-based practice model. In MAP, it has been 10% due to the challenges that we face in implementing this model with the API families. With PACS, we did select also caring for our families as the community-defined evidence-based practice, which is piloted by the Asian Pacific Islander families by, as you have heard, Asian Pacific Counseling and Treatment Center. And PACS was very happy to have the opportunity to be included in this collaborative, which opened up the sliders because it allowed us to serve our API children and families with an API, with an evidence-based practice model that was family-focused, strength-based, and that also allowed our case management services to be a core component of the model. PACS serves a diverse API community, so a model that provides the family with services as a team of clinicians, psychiatrists, paraprofessionals who have lived experience in the communities they serve and have language capacity to work with not only the children, but the monolingual parents would work best. And CFOF has expanded our staff capacity because the APCTC collaborative has provided training and has not restricted the amount of training for staff or the number of people that can attend the training. So we have trained a lot of our case managers and our clinicians in this model. Also, it was a strength that the APCTC model, the CFOF model, had as the developer as a consultant also to ensure the fidelity of the model. And PACS has participated where we've had the developer online with us at our fidelity and oversight committee meetings. Since 2010, PACS has provided CFOF services to about 15% of the total population of the EBPs at PACS. So with the strengths of the CFOF, it's family-focused, strength-based, community-based interventions, case management services as a core component of the model. It's multidisciplinary. It allows for training and implementation that is conducive to our API children and families. I'm sorry, I'm still back here. And cultural competence is one of the guiding principles of the model. I wanted to address culturally responsive treatment since we are talking so much about culturally responsive treatment for our evidence-based practice models. And I refer to APA guidelines for multicultural education, training, research, practice that recognize that attitudes and beliefs can negatively influence interactions with a culturally different population. They also recognize the importance of multicultural sensitivity, responsiveness to understanding culturally different, and applying culturally appropriate skills in clinical and other applied psychological practices. And this is taken from a webinar by Huey on evidence-based psychosocial treatments for ethnic minority youth in the Journal of Clinical Child and Adolescent Psychology. The Asian Pacific Policy and Planning Council Mental Health Committee had conducted a survey with providers of evidence-based practice models, and I would like to report on that survey. "44 clinical staff were respondents of the survey, and it analyzed the cultural and linguistic barriers faced by API clients when utilizing PEI evidence-based practices. And the agencies that participated were Asian Pacific Islander Alliance, Special Service for Groups, Pacific Asian Counseling Services, Pacific Clinics, Asian Pacific Family Center, Little Tokyo Service Center, South Asian Network, SSG Asian Pacific Counseling and Treatment Center, Korean American Family Service Center, Koreatown Youth and Community Center. There were a total of 29 respondents, and there were 24 adults, 17 older adults, 8 children, ages 0 to 16, 7 children, ages 0 to 5, and 6 children, transition age youth, ages 16 to 25. And the respondents were trained in the following EBP models: child-parent psychotherapy, 8 of them, caring for our families, 14, CORES, 4, group CBT for major depression, 2, IPT, 8, MAP, 5, MHIP, 4, motivational interviewing, 25, PEARL, 6, reflective parenting program, 4, seeking safety, 37, TFCBT, 12, triple P, 4, and another 2. So you can see that there was a diverse group of evidence-based practice models that were surveyed in terms of their effectiveness with API children and families. The primary language of the respondents for this were Chinese Mandarin, Chinese Cantonese, English, Gujarati, Hindi, Japanese, Khmer, Korean, Punjabi, Spanish, Urdu, Vietnamese, and you could see by the next chart the limitations that were found in providing evidence-based practice models to the population. And as you can see, the largest or the most common challenge was the lack of translated materials in the languages that was needed. Also, second to that were the different requirements for each EBP, and that there was more administrative work working with this population and implementing EBP practices. The age groups served were the next chart here. Age group served by the respondents, you will see here in this chart. And the languages of the respondents. If you aren't familiar with Gujarati, that is an Indian language, and Khmer is the language of Cambodian. Also, there was a focus group finding. Focus group as well as the survey and major challenges implementation were also addressed there. And one of the issues was, again, the language, that the outcome measures were not translated into the languages that were needed. Also, the developers were not willing to be flexible. Developers were contacted to see if translations could be made in the various EBPs and the outcome measures, and they were not willing to allow that. In some instances, agencies asked the developer if they could share translated materials with other agencies, and the developer also did not allow that. There also was a finding that there was a lack of evidence-based practices for older adults. Also, cultural cues were not appropriate for APIs, such as in the Seeking Safety model. References to Helen Keller and Jesse Jackson in the outcome surveys have no meaning, for example, for a refugee from a country like Vietnam. There was also a demand on staff time, of course, to interpret, translate, and administer measures to monolingual or LEP, limited English proficiency clients and families. I wanted to give you some final words from the CFOF intervention manual. Has been referenced before by Dr. Sheila Wu, and about cultural competency. And I'd like to reinforce this. In order to meet the needs of families, the helper must understand the world from the client's point of view and provide the help needed in a manner in which it can be used. Cultural competency is the ability to understand, to the best of one's ability, the worldview of our culturally different clients and adapt our practice accordingly. Thank you very much.
Thank you, Ms. Michi Okano. And so that wraps up our presentation today. And so, we will continue to work with our developer, work with the County Department of Mental Health, and I'm sure we will continue to have barriers and struggles, continue to have more lessons that we will learn in Los Angeles. And so this concludes our presentation. Are there any questions?
Yeah, so this is Christy Higgins with CIMH. I wanted to thank you all for the presentation, and definitely, as you were just beginning to do, make sure that we let folks know if there are questions to please use the question box in terms of the feature affiliated with the GoToWebinar information so that you can pose questions. There are a couple that have come up already, and they're kind of logistical questions, so I'll just go ahead and state them out loud, and you all, whoever can respond would be appropriate. But for those of you who are listening, please use the question box to ask the questions. So one is the intervention manual free?
Okay, intervention manual is something that we provide to the staff who come for the training. So we have a training binder. It's a 2-day training that we put out, and the intervention manual is something we go through with them. So it's not something that we can send out to anyone. So it's part of the training.
Okay, great. So I think that answers that question. Another question that has come in is where can we find more resources on the Caring for Our Families model?
Resources as far as what the model calls for, or what kind of resources? Can you be a little bit more specific?
Well, I can only repeat what was written by the person who asked the question. So that was just kind of what was stated. So where can we find more resources on the Caring for Our Families model? If that person wants to clarify a little bit further using the question box, I can give you more details.
Okay,
But
or if there's specific questions about this model, they can always call me or email me. And we can make the contact information available.
Okay, so the person said that I'm still a little confused about the outline of the model related to the Caring for Our Families model. So I don't know, maybe you can do a little bit of clarification around that, and then that person sounds like you're inviting them to also contact you directly, right?
Yes, that would be fine.
Okay. Okay, well, we're still waiting for other questions to come in, so while we wait, did you want to do a little clarification about the general outline of the model?
Yeah.
And then in the meantime, others are invited to please send questions over the question box.
Okay, so one of the other areas where you can find more information is from the publication. There is information in the publication that talks about what the model is. Introduction to Family Connections, and then the replication. As Dr. Karen Cheng-Lim had mentioned, that as far as the specific intervention that's used, there's no 1, 2, 3 spelled out where you have to do certain things. Okay, the whole concept is to understand where the family is, what are some of the strengths that the family presents to you, and how can you help them to utilize those strengths to improve their struggles. Okay, so the model itself doesn't tell you, okay, you have to do individual family session one time using specific technique. It doesn't work that way. And that's why this is the beauty of the model, is that there's flexibility in how you provide the therapy to each individual family. So all the interventions are individually tailored. And it could include therapy, it could include case management services, it could include linkage, and all of the core services that I mentioned in the previous slide.
Okay, great. Well, thank you for clarifying that and giving a little bit more context for how it actually works. I am looking at this point, and I see another question that's come in. It says, how would you recommend others to get involved? I'm a community volunteer, a member of the Asian Coalition of LADMHs, and member volunteer of NAMI San Gabriel Valley. I go around sharing my personal story of my mental health recovery. When does your committee meet?
Okay, we're
Would you
looking
like
at
me to repeat?
see who would be the best person to answer this question.
Would it be helpful for me to reread the question, or are you all just figuring out who's going to respond?
Yeah, if you could reread the question, that would be great.
Sure. It says, how would you recommend others to get involved? The person says, I'm a community volunteer, a member of the Asian Coalition of LA County Department of Mental Health, and a member volunteer of NAMI San Gabriel Valley. I go around sharing my personal story of my mental health recovery. And then they ask, when does your committee meet?
Okay. So this person, sounds like this person would like to get involved as maybe part of our community advisory board. So initially we were meeting quarterly. And so right now we're only meeting as needed. And the reason is because at the beginning of our project, we wanted more feedback from the community so that it can help shape, I guess, the priorities of what the program needs and what each different community needs are. And so now we're meeting as needed. So if this person is interested to participate, that would be really, really great, and it would benefit us to hear from that person's perspective. So my suggestion is also to perhaps give my contact information, and then he or she can just call me or email me directly. And that would be the probably easiest route to go.
Okay, great. Thank you. Another comment actually has come in, and it says, thank you for all of your lectures, and one suggestion is to please use whole words instead of abbreviations unless you repeat them in the same slide. I think as we all become more familiar with kind of our internal language, we may not always be aware of those of us who are not maybe as fully connected and familiar with the abbreviations that are used.
Yes, thank you for the reminder. We apologize for that.
Yeah. And then in terms of your contact information, will we be able to, in the slides, will that information be provided, or for the presenters, do we have your permission to share your email information with all of the participants?
Yes, that's fine.
Okay. Okay, so we will share the contact information of the presenters with those of you who have registered online. So we'll send you their email addresses. Okay. I'm looking to see if there's any additional questions that are coming in. It's kind of up. Here's another one that's come in. This person says, hi, my name is Jenny Tay. I'm at CAA, a case manager, and just want to clarify that can case managers assess or evaluate client mental health for further support services needs? Does that question make sense? Should I repeat it?
Sure. Go ahead and repeat, please.
Okay. So this person is a case manager, and they want to clarify, can a case manager assess or evaluate client mental health for further support services and needs?
What we've done with our CFOF program is the case managers work alongside the therapist. So during the intake process, the case manager would be present to help assess for case management needs that they could support as a team approach. But the therapist is primarily responsible for assessing for the mental health disorder and the medical necessity.
Okay. Okay, great. So they could provide some support, it sounds like, in that process.
Yes.
All right. So I was just beginning to say, so thank you for that question for all of you who provided questions or comments so far. I say thank you for this information. What I'd like to do at this point, it's about 1:45 to noon, and we are scheduled to end the webinar kind of at any point. So I wanted to just provide this last opportunity that if you have any final questions or comments as a participant, to please pose them now. And if not, and I'm not seeing any coming up, I wanted to just invite the presenters, if there's any kind of final comments or summary comments that you would like to make, to invite you to take a moment to do that at this point. Any comments from our presenters at this time?
Actually, I'd like to somewhat answer the question that was posed earlier about clarifying the outline of CFOF. And Dr. Wu mentioned that there is no specific curriculum, unlike other EBPs that perhaps we're used to seeing, where it's a manualized step-by-step intervention. So as you'll see on one of the resources about family connections, so basically the Family Connections program, or CFOF, it operates from an ecological developmental framework, as mentioned, and it's developed primarily to prevent child neglect. And the way the program conceptualizes is the problem evolves when risk factors related to the child, caregivers, the family system, and the environment challenge the capacity of caregivers to meet the basic needs of the children. So CFOF, or Family Connections, that's what it focuses on, is to work on the risk and protective factors as it relates to child neglect. And it uses the home-based, family-centered model and tailors the interventions in order to meet the goals that are identified with each specific family. So there are guiding principles to the interventions, and that includes the community outreach component, individualized family assessment, the tailored interventions, building the helping alliance, empowering the family, the strengths-based perspective, cultural competence, and developmental appropriateness. So you'll see in the intervention manual that there are guiding theories, guiding principles, and the process is outlined, but it's, as Dr. Wu mentioned, it's not going to give you a step-by-step, intervention outline.
Mm-hmm. Okay. All right, thank you for those, that other kind of response or extended response to the earlier question. Two others have come up very quickly, and so I think if you all are willing, it would be helpful to go ahead and ask these. One is, do you know if this model has been piloted in the Filipino-American community? That's one. Any quick responses to that? Has it been piloted with the Filipino-American community?
Not specifically to any of the Filipino agencies around here, but we do serve the Filipino community within our agencies.
Got it. Okay, great. And then the other question is, of the community-defined evidences, or CDEs, CDPs, what about CFOF works well with APIs? Or is it more of an issue of getting more APIs through good O&E who would benefit from the CDE? That's a whole lot of acronyms. But is that making sense? So of the community-defined evidence, what about the CFOF works well with Asian Pacific Islanders? Or is it more of an issue of getting more Asian Pacific Islanders through good O&D who would benefit from the community-defined evidence or practice?
I'd like to answer that. This is Michi Okano with the PACS agency.
Okay.
And it works well because it's a family-based and strength-based model. And also it allows for cultural interventions by a case manager who is matched with the client for language specificity and for culture.
Okay.
Also, the model was piloted with Asian Pacific Islander communities.
Mm-hmm.
So that was one of the reasons why we chose at PACS to implement the CFOF model as well.
Great. Okay. All right. Well, that was the last question that came up. Let's see. If someone is interested in the training, the 2-day training that you all spoke about, again, they can contact you all directly to figure out how to get connected, I would assume.
Yes.
Okay. I wanted to clarify, someone else had asked about the copy of the PowerPoint presentation. Yes, we sent that out in advance, and we'll be happy to resend that out along with the presenter's contact information, so we will do that. And I think that will do it. What I will say then, as I just kind of do take a moment to thank again our presenters for their presentation. I also want to thank all of you who participated in the webinar for your questions and your willingness to kind of go through the entire opportunity as well as hear the Q&A. I wanted to let you know that this is our final webinar in the series that we've been promoting over the last few months, actually. And I want to invite you to please check out the CIMH website or our CIMH YouTube channel within the next couple of weeks so that you can review the recording from today's webinar, as well as any of the previous recordings and PowerPoints that we've done on the Latino, African American, and the Native American communities. We also wanted to invite you to join us for the upcoming summit that we'll be having on building the evidence for cultural and ethnic community-defined practices, which is taking place on May 30th, 2014 at Anaheim Crowne Plaza. So as I mentioned before, we are going to go ahead and disconnect from the webinar right now, and as we do so, you will get a prompt to complete a quick evaluation, and we invite you to do that. So thank you again for participating in the webinar today, and with that, we conclude our broadcast.